Excited to be glad to be speaking to the bright minds of the EMBS IEEE student chapter. Let me start sharing my screen and we'll take it from there. Um, okay, I think so. There we go. So I think you should be able to see my screen in the presentation mode. Is that correct?
Yeah, we see it.
Perfect. Thank you so much. So thank you again. And I'll be taking the next 40 minutes to 50 minutes, depending upon your availability, talking about some of the things that we have been doing in the space for healthcare using artificial intelligence and machine learning. So I would love this to be interactive. So please feel free to stop me at any point of time and ask questions. And I'll be really happy to answer those as we go along. So basically, I come from a place called IIIT-Delhi, India. Um, that's my institution where I currently work. Um, and my personal context is that I have been working in the space of data science, AML for healthcare for the last 15 years or so. I did a medical graduation from a place in the northern part of India. It's called Amritsar. And after doing my medical graduation, I was fully convinced that I actually wanted to go into research and not be a full-time clinician because I was always excited by mathematics and physics while pursuing pre-med school. But I clearly saw that once in clinical practice, that takes a back seat. So I wanted to get back into my connect with the quantitative aspects of science, specifically the mathematical aspects, and that's when I made a conscious decision to pursue a PhD in genomics. And at that point of time, way back in 2005, when I made this switch, genomics was the genomics revolution was in full spring. We were quite hopeful at that point of time that whole genome sequences would give us a lot of answers about complex diseases that we are otherwise not able to understand and be able to make more predictions about how people react to different stimuli and basically develop sicknesses and get healthy. So my major motivation was to really start looking at aspects of genome that make people um, sick in some cases. For example, in respiratory diseases, that was my major focus area in my PhD. So while I was doing my PhD, I was also very well connected with the medical side of things. I was working with an institute in Delhi called All India Institute of Medical Sciences, which is one of the largest tertiary care centers, hospitals in India, in New Delhi. And there we were working in respiratory diseases. And so for the last 10 years or so, I've been working with AIMS New Delhi as a fellow of the Wellcome Trust, DBT India Alliance as well. And during this time, I have had the opportunity of being a visiting faculty at the Stanford University School of Medicine in the Department of Biomedical Informatics Research, where my work was in the space of biomedical informatics that can bridge um, decision making using EMR data across the continents. And I'll speak about that in some of my slides. So recently, we at IIIT Delhi, we had an initiative, and I had the opportunity to lead that as to create a center of excellence in healthcare, where the idea is to bring more AI technologies and digital data, digital health technologies in the space of healthcare. So essentially, in India, we need that a lot because there's a huge gap between the number of patients and the number of clinicians that we have. So that was a personal context. And if you're wondering what IIIT Delhi is, it's an engineering university. So although my background is in medicine, I teach and I conduct research and at IIIT Delhi. It's a Delhi state government university, and we have a emphasis on conducting world-class research, and also an emphasis on creating interdisciplinary programs. And so that's where the CS computer science plus X is one of our sort of key thrust areas. So that X can be computational biology, that X can be applied mathematics, that can be AI. So computer science plus X is our guiding principle, and I work in the Department of Computational Biology. And I'm also affiliated with the Centers of AI and, as I said, for Center of Excellence in Healthcare. So I'll speak about the use of AI in healthcare from three different standpoints. So when we think of AI, we think about data, right? And we think about how can we start training our AI systems and start making decisions. But this first starting point is data. So many times, I mean, you might have heard many talks talk about AI from the standpoint of supervised learning, unsupervised learning, and reinforcement learning. That's one way to look at AI. But I also take another approach to think about AI from the standpoint of how healthcare sees it as. So when we look at data in healthcare, these are either data that are already available as structured data, um, typically EMR databases, neat, cleanly organized CSV files or tab delimited files residing in databases. Uh, and that's one form of data, right? And then there's unstructured data, which is mostly 80% of data in healthcare is actually unstructured, which is in the form of text and images that are linked to these texts and so on and so forth. And then there may be situations where we don't even have any data and we need to really simulate on the basis of the context. So I'll take this approach to talk about our work in healthcare from the standpoint of structured data, unstructured data, and, um, and simulations where there's very little data. So AI with structured data, the example that I would like to use is our work in ICUs. So ICUs are one of the most data-rich environments. And depending upon the size of the ICU, how many beds are there in the ICU, um, um, there is routinely gigabytes of data that are generated in the ICUs. So our ICU, which is an 8-bedded ICU at All India Institute of Medical Sciences, AIMS in short, um, generates about a gigabyte of data per day, routinely generated and routinely lost. So, and most of the ICUs around the world do not warehouse these high resolution data, right? So, in electronic medical records, there may be nursing notes that are collected at every hour intervals or so on. There may be physician charts that are collected maybe at 6 hours or 12 hours intervals, but data that are collected on a real time basis, because every time a patient gets admitted to the ICU, they get plugged on to these monitoring equipment, which start recording heart rate, pulse rate, oxygen saturation, respiratory rate, and so on. So these are data which are many times 512 hertz or 256 hertz, and these are rarely ever warehoused. So there's very few initiatives around the world that actually store these data. And we thought that to really train AI models, that's essential first step towards warehousing such data. So what can we do with that? So we call this initiative as Safe ICU initiative. Safe ICU stands for Sepsis Advanced Forecasting Engine. Sepsis is one of the biggest killers in the ICUs. And it's nothing but bloodstream infections and response of our body to infections in a way where it becomes unregulated. and so organs start to fail, and typically it's a downhill journey for the patient from there on. However, if sepsis is recognized early by the clinicians, the treatments are really simple. Antibiotics and fluids are examples, and so these can potentially reverse sepsis. So there's a window of opportunity before which the patient gets onto the downward spiraling path. And that's what we wanted to do with these data that we were warehousing. And now this slide is a little bit old. Now we have warehoused about 1.5 million patient hours of continuously monitored data in our Safe ICU project from 2016 until now. So we started really lean because this was a publicly funded project. We are not a, we are I mean, so at that point of time we did not have a lot of industry support. So we started lean by actually building our software and hardware connects from the ground up, right? So you can see here we started really by connecting monitors by Raspberry with Raspberry Pis, and basically writing our own software to query the to query the monitoring systems using APIs to fetch these data. And uh, that was a long, arduous journey, about 6 months, finally to be able to get to the resolution of data that we required. And as of now, we have data collected every second, every 1 hertz resolution, and also potentially at 512 and 216 hertz. Currently, we are looking at 1 hertz because of the clinical utility of such data sets. So every second, we basically are collecting data on heart rate, pulse rate, oxygen saturation, respiratory rate, and so on. But then there's other sources of data as well in the ICUs. For example, doctors write treatment notes, treatment charts, which are written typically about a couple of times in the day at every 12 hours intervals. Then there are laboratory investigations that these patients may be investigated for. And those happen typically once a day or sometimes at a couple of days intervals. So these are not uniformly available data. So we integrated all these different scales of data in our ICU resource, in the Safe ICU resource, and then started to think about generating value for the clinicians. And since we are starting out early, right, so we did not have a lot of data to start making AI models. And one of the things as a clinician, I do realize that if we start giving predictions to clinicians, they may not even pay attention. We need to start with something that clinicians understand and connect with. And this is true for, I think, almost all of biology when you are applying engineering to medicine and biology, that many times we are very much excited by the cool piece of code that we may have written or the cool model, but but if it does not connect at a level with the clinician or the biologist, many times that model may not get adopted. So we always begin with the end in mind, which is adoption of models in the clinical or public health settings. So as we were building these models, we started generating early value for the clinicians by asking them what could they be doing with these big data if these were available to them, right? And one of the things that they said, we would like to understand how much is the time duration in which babies are in the right oxygen saturation range in our ICU. Okay, even without making a predictive model, can we just know, are our babies staying in the right oxygen saturation range or not? And that is a quality measure of an ICU all around the world. It is used as a quality indicator that that children and babies should be maintained in the right oxygen saturation range of 88 to 95%, because if oxygen is if the oxygen saturation of a kid or a baby is below 88%, they may develop hypoxia and organ failure. If it is more than 95%, especially in young babies, it's toxic and it can lead to blindness in a condition called retinopathy of prematurity, because our retinas are very sensitive to oxygen, especially the developing age retinas. So you were able to do this on an ongoing basis. You can see the histograms here. You were able to demonstrate to them, okay, that we need to improve the quality indicators of our ICU, and need to bring these oxygen saturation ranges in the right range by paying more attention and raising more alerts. Similarly, monitoring the usage of antibiotics in the ICUs, because you may know that antibiotic resistance or antimicrobial resistance is one of the biggest threats that the humanity is facing. WHO has said that in the next 30 years or so, it will be the biggest challenge, and may start claiming more than 10 million lives a year, if we don't take effective measures um, um, to prescribe antibiotics in a reasonable manner. So one of the measures to ensure that is to monitor antibiotic usage. And here is, for example, a simple weekly chart, a radial plot for monitoring antibiotic usage across the weeks in our ICU. But once we had these data, maybe after a couple of years, we started building models that can be predictive, right? So when I say predictive, I mean predictive from the standpoint of clinicians, not just from the standpoint of computer scientists, because many times to computer scientists, when we say a predictive model, it might just mean a detection model. For example, um, prediction of tuberculosis in a chest X-ray, or prediction of a breast cancer lesion in a chest X-ray, is actually not prediction from the standpoint of clinical utility. It is actually detection or diagnosis, right? So prediction is something that doctors may want to make into the future about, is my patient likely to, let's say, develop sepsis, or develop organ failure or shock, or in a more non-critical setting, is my patient likely to develop, let's say, breast cancer in the next 5 years or so, right? So so I think this is a often confusing terminology between prediction and detection. So we use it in the sense of, for example, can we look at the data before this black line, which is the point at which it's an observation window, right? So we look at this data, and we do not look at this data, which is the window of opportunity, to predict what might happen at the red line, right, in the future. And this may be 3 hours, 6 hours, 12 hours, depending upon how much lead time a certain condition requires in the ICU settings. For some conditions, even 30 minutes is good enough. For example, shock, if you recognize it early in time, simple things like fluid infusions and dopamine infusion can actually help a lot, right? So these are the kind of cohorts that we started building from our data to start making predictions, right? And another thing that we were doing is we were experimenting with some novel modalities in the ICUs, uh, which to our surprise nobody has had explored so far. A very simple thing such as thermal imaging, right? So temperature is a vital sign, but rarely temperature is used in a systemic fashion. I mean, the way we use temperature is local at a given site. So we wanted to look at temperature patterns as a systemic pattern uh, on the baby or the child, for a simple reason. For example, shock. It is known that in a condition called shock, which is a very common outcome in sepsis that I was talking about. So shock is a condition in which there's a mismatch of body oxygen supply and demand. For example, if there's sepsis, what happens is that organs demand exceeds the supply, and in that case, organs start to fail. And when that starts to happen, our body gets into a mode where it diverts the blood from the less important organs, such as skin, to the more important organs, such as the brain and the heart and the lungs, kidney, etc. Right? So what that means is that when blood flows get diverted, temperature patterns also change on the body. So it is known in first year medical school that um, hands and feet are colder, and abdomen is warmer in shock, just because the blood is diverted away from the peripheral, less important organs to the more important central organs. And here you can see that happening. This is a kid who is in shock, right? And you can see that in the thermal scan of the child, the feet are barely visible. And when the kid received treatment of shock, for shock, essentially the gradient of temperature between the periphery and the center, which is the abdomen, actually became less. And here you can see that it is actually fully reversed. And that is a gradient line that you can see on the right hand side, that there is a difference in the temperature between the center to the periphery in shock, which actually reverses when the child is returning back to normal. And if you're wondering what this dip is, this is the diaper that the child is wearing. So you see a dip there, right? And then we automated this process by using computer vision models, because we wanted to run these models on an ongoing basis. And very simple approaches, such as even non-deep learning approaches. We were not yet doing deep learning because we did not have enough data when we started out this project. So we started out with simpler forms, such as a histogram of oriented gradients or Clahe features, to segment out the body parts, right? And basically calculate the centroids of these body parts, and then use these as features in our predictive models. And then we use these to predict what would happen for forecasting of shock at 3 hours, 6 hours, and even at 0 hours, which is a detection time point, like the diagnosis time point, right? So we could see that our models for segmentation were performing really well. The ROCs were upwards of 95%, even 99% in some cases. And we were confident that we can now build models with these features. And that's what we did. We essentially built models, including these features, into predictions, and we could see that at 12 hours, we could gain about 75% positive predictive value for prediction of shock, right? And you may think that, is that good enough? So I would just like to remind again that it is different from a detection model or a diagnosis model, where um, accuracies as high as 95% are commonplace. But when you're looking at prediction 12 hours down the line, 24 hours down the line, there are very few models available which actually perform good. So, and with a positive predictive value, which actually is useful for clinicians to make decisions. Secondly, we did not have any baselines from clinicians on what do they think about predicting shock in patients in the ICU setting. So our baselines were really very strong. So the baselines that we used were shock index, which is, as I said, a minute by minute or a second by second calculation uh, of what the heart rate divided by blood pressure adjusted by age looks like. So that's a very sensitive index, and typically doctors would not make use of shock index because it's not usually available on an ongoing basis as a on a second to second basis. So we were already using a very sensitive measure as a baseline to compare against. So that's what actually led us to believe that we can actually use these models on a more uh, continuous setting rather than snapshots. Uh, and we have a preprint that is currently in review. You can go and read it on medRxiv, which actually extends this framework to a continuous video-based monitoring setup using thermal images. That's one direction that we are currently looking at. But there's another direction that we are interested in. Thermal imaging is a non-contact and a non-invasive modality. So unlike puncturing, for example, the central venous, for measuring the central venous pressures, you have to actually put a catheter into the veins, and that itself is a factor for causing sepsis, right? As opposed to clicking the thermal image, which is a non-contact and non-invasive modality, which does not even you don't even need to touch the patient, right? So it can be done in a remote manner. So currently what we are looking at is, can this modality be actually scaled up to peripheral healthcare settings where where we do not have enough intensivists, especially in settings like India, right? And can we use these models um, in the hands of peripheral health workers, who can actually who are trained but non-specialized workers. They are not doctors, but they provide some of the very basic services in primary health in the peripheral health settings in India. And essentially clicking images that can be transmitted to over the cloud to our servers and giving predictions on shock and non-shock. And there we are using deep learning models, UNet for segmentation, and state-of-the-art deep learning models for classification as well. So that's what our current goal is towards, taking our models out into the community settings. The next question that I would like to emphasize, that all of these models in healthcare settings um, inevitably come across, is the question of generalizability. So if I make a model in one ICU in India, is it good enough? Perhaps not, because you would want those models to actually be generalizable to other settings as well, right? So, and that's what we are testing uh, in, in data sets that are publicly available from ICUs across the United States. One of those data sets is called the MIMIC data set. It is a data set from Beth Israel Deaconess Hospital, Harvard, in collaboration with MIT. But it is an adult ICU data set. And remember, our ICU data set is a pediatric child ICU data set. So we're not just testing generalization across continents, but we are also testing generalization across age groups, right? And the other data set that we are currently using is another data set called eICU data, which is uh, which is maintained by Philips, wherever the Philips monitoring system are installed. It's about 200 ICUs across the United States settings, uh, and essentially looking at those 200 ICUs and also seeing how can our models generalize. So I'll just give the bottom line of this. You can go read the preprint on medRxiv again. If you just search our lab or my name and generalizable or generalized predictions and shock, you'll find the paper. Um, but the long story short, what we find is that we did two types of models. One is state-of-the-art time series models using features that that calculate all the features, including linear, nonlinear, complexity-based analysis, chaotic time series features, so on and so forth, right? So not just simple statistics of time series, but also periodic features such as a Fourier transform, entropy features, which are more nonlinear features, complexity features, for example, the Lyapunov exponent and complexity analysis, right? So we thought that do we really need to do deep learning if we could mine a lot of domain engineered features on these time series? So that was our question, because deep learning comes with its own expense. It's a computationally expensive procedure, and also essentially requires specialized hardware. Although you can use Google Colab these days, but still it requires specialized training. So we compared these two types of models, and the long story short, if you are learning and deploying models on the same ICU, the domain specific features actually performed as well. But if we were uh, generalizing across age groups and generalizing across continents, both of these model types actually showed a huge drop in generalization, right? To the, I think there was 30% drop um, uh, in um, in the deep learning models and 40% drop in the time series based models. But yet we could say that there's a 10% increase in generalization potential if we were to use deep learning. And that's an ongoing challenge that we are currently addressing, that how do we build models that generalize across places. Our recent results actually point out that this is most likely because of the very different age groups that we are looking at. So if we just restrict to ICUs which are in the same age group, we are actually seeing up to 95% generalization in the 200 ICUs whose data are available across the US settings. But for the pediatric, when you deploy those models for the pediatric ICU, suddenly your accuracies drop quite a bit. So deep learning is the way to go if generalizable models have to be built for different settings, and there's a lot of scope for improving these models going forward as well. So that was my first sort of use case on structured data. And I would like to go next on to unstructured data because that is also uh, a very prevalent form of data in our in clinical and public health settings. So one of the examples where unstructured data and things that we can learn actually uh, uh, is a paper from last year published in Nature as a letter, which was huge, which was heavily discussed because the paper actually used unsupervised word embeddings to recapitulate to recapitulate material science properties as well as the periodic table would tell us, right? So just by training models to read literature, the authors were able to predict material science properties just by reading the text. And they used very simple models. These are not really complex word embedding models. I'm sure you know about word embedding models, which uh, but to briefly mention what how do these work, essentially what these models do is that these models learn a latent space for the text by representing each word as a vector, right? So and just as with vectors, you can do algebra and you can calculate similarities, cosine similarities, and so on and so forth. You can actually also look at what is that latent space which collapses some of this information in a low dimension instead of the full dimension of the corpus of words present in the full corpus, right? So essentially, by representing words as vectors using the word-to-vec algorithm, which is a very standard algorithm in natural language processing, these scientists were able to recapitulate some of these properties. Now, these days, word embedding models are actually also quite complex. For example, you also may have heard about transformer models or the BERT models, which are typically employed by Google. Scale data, which predict what is the next word when you are searching the Google search box or you're typing in your Gmail, right? So it predicts the next word. So, but with very simple models such as word-to-vec, they were able to do that. So that encouraged us to ask a question that can we learn models that can that can actually derive insights that we can deliver in a public health situation. And why was that important? So that was important because if you look at a lot of information that is put out about healthcare in public health, it is in the form of advisories, um, text, right? So you can think about COVID and look back, and there's lots of advisories issued by the WHO about COVID, right? There's a lot of news that can be used to mine data or to mine information rather about what is happening in the public health context, right? So our motivation was that in our ICU, a lot of sepsis readmissions were happening because a lot of people do not know how to prevent sepsis in the first place in their homes, right? So we thought that if we really need to solve this problem, just predicting it in the ICU is not enough. We also want to prevent it in the community settings, right? And in the community settings, let alone people who are connected, not connected with healthcare. Even doctors do not read WHO advisories as often as, for example, we need to, right? So our idea was, can we provide all the right information that is out there in the right format to the right people who we really need to reach out to at the right time, right? So our thought was, can we make use of WHO advisories on water, sanitation, and hygiene, uh, WASH in short, and and connect that with interesting pieces of news and information that is happening, and provide that information in local language to the people who need it the most, right? So that was the idea of the project that we call the Wash Karo project. So Wash Karo basically, Karo in Hindi means do. So essentially, it's a mix of Hindi and English, which says that do wash your hands, right? So that's the essential idea. So this became really important when COVID became a problem and it struck India. So our Wash Karo project was repositioned to address COVID. So what we did was we started looking at WHO advisories and the advisories by CDC and the government of India. We started matching them with news pieces because a lot of misinformation was floating around, right? So we did automated text summarization using NLP. We generated an similarity scores between these pieces of information, and basically did human vetting of these articles through a team that is a clinical team, to look at thresholds at which we should say that this is a threshold at which we should put a similarity, right? To just set those thresholds. And once we were able to learn those thresholds, we were able to then automate this process of, on an ongoing basis, uh, filter in the right information and filter out the wrong information, and use the Google text to speech APIs and translate APIs to deliver it in local language to people, which is Hindi, and then also incorporate feedback from people. So if you go, you I mean, so there was a feedback button which said that did you find this piece of information about COVID relevant or irrelevant? And what we found was this was a first machine learning based application to raise wash awareness for COVID around the globe, right? So there wasn't any application available back then. We presented it at the WHO, and we also showed that essentially, in the limited time that we had to work with COVID data, uh, we were able to show that with user feedback about right and wrong, our AI systems actually, our previous pipeline actually got better and better, and the count of irrelevant matches went down while relevant matches kept going up. Right. So why do I say that we had a limited time? Because at some point of time, Google's policies changed, and and they took off all the apps from Google Play Store, which were providing COVID information. So our app was also taken off the Play Store, but then we made an appeal because it was actually present on Play Store before COVID, and now it is back on Play Store as an app for tuberculosis, because only government bodies are authorized to spread COVID information. Another key insight that we found was more females were engaging with our app in Hindi than males. And although more males were engaging with the app. So this is an insight into segmentation, that if we are developing messaging systems for public health, and our app was one of the first machine learning based messaging system, we need to take into account the demographics and languages, especially in a country like India, right, where there's so much of diversity of languages. So if we need to connect, so we could show that there's still a divide, a gender gap in education in Indian settings, and we were able to show that it's really important to connect uh, in languages that can bridge some of this divide. So also we were using word embedding models and NLP models to make sense of the literature that was happening around the globe, right? So if you're a lazy researcher, you might want to use AI for extracting out the information from the 90,000 papers that WHO has vetted about COVID, right? So, but it's not just about being lazy. Also, it was about the crazy information that was actually being put out in literature. You might have realized that there were papers that were put out saying hydroxychloroquine works in COVID in very high impact journals, and these were retracted. And essentially, literature was changing at a very fast pace. So way back in April, we again put forth this web application using word embedding models to essentially summarize what was happening in the literature, and we called it COVID NLP. And now the new sort of version of that is what we call evidence flow. So this is also, all these works are available um, as publicly available web applications, as well as either published papers or in review, but also available as preprints online. So now basically that evolved into something we called evidence flow, because now we were able to track these word embeddings, which is called chronotropic diachronic word embeddings, right? So you have a word embedding. So for example, each dot here is a word in the vector space, right? And you can see that these words actually clustered in the vector space. But now these clusters could actually change in time, right? And that's what we were looking at, that how did these word embeddings or the diachronic word embeddings actually give us more information, or how did these change? And we used these clustering algorithms, and we mapped these to something called alluvial diagrams. There are many names of such plots, where each of these clusters actually maps to a streamline here, right? And in a totally data-driven manner, we were able to show that how from March 2020, which is this part, this vertical segment on the left, to August of 2020, which is the right segment, COVID actually gathered more and more evidence of being a thromboembolic disease, a coagulopathic disease. And so you can see that thin lines of evidence actually came together to form a strong evidence or cluster in the word embeddings to point that COVID actually is not just a respiratory disease, but it is also a coagulopathy. And that's, I mean, people are reporting strokes that were related to COVID. People are reporting heart attacks that were that were related with COVID, skin rashes, and so on and so forth. And the latest in this is that you might have heard that even the vaccine that we are one of the vaccines that we are currently having in the market, one of those vaccines has blood clots as a side effect that is currently being actually examined, right? So which means that evidence can be garnered from literature ahead of time, or at least in step with time, if we were to use AI models. And what we were able to do was we were able to, and if you go back and read this paper online, you can go visit this link. What we were able to do was we were able to construct these networks and to do link prediction on these networks on what may come up next. And which means that you can not just track emerging evidence, but also maybe predict what may come up next in unstructured data. And I mean, our models show that psychiatric complications of COVID are emerging as a major theme in the COVID research in the coming months. So that's our prediction for the March, and you can go back and check that. Finally, I think I'll spend the next 10 minutes or so on two different aspects. One is both of these relate to context in AI deployments. The first is when you don't have any data, right? And you just can rely upon simulations, right? So that's that's an example, for example, of reinforcement learning. And I'm sure all of you know, being an engineering group of students, that the algorithms such as reinforcement learning are the ones that have been used in training models that just train, I mean, allow Mario games to be played in an automated fashion, right? So these models actually learn to play Mario games just by giving a reward function and setting a condition that you have to stay alive, you have to garner maximum score, and you have to finish within a certain amount of time, right? And then there's an environment and a set of actions that the agent can take, and essentially letting them learn on its own. But in the biological setting, this also has a lot of applications. The most recent of this is, you might have heard about this recent announcement that protein folding, which is a huge challenge in biology, right? Um, Using algorithms which are AlphaFold from Google DeepMind, these algorithms actually achieve the state of the art in folding proteins, right? And why is that important? If you can actually learn to fold proteins, you can make better drugs, you can even make better vaccines, right? And Google's algorithms have been performing well in this space for many years. Their previous algorithm is AlphaFold 1. Now it is AlphaFold 2. And there's a challenge called critical assessment of techniques for protein structure prediction, or the CASP challenge. But this year, I mean, in 2020, you can see that the quantum of difference between AlphaFold 2 and the next best algorithm is huge. And that basically led the protein scientists to say that protein folding is now a solved problem in biology, right? So we are not in that space of doing protein folding and molecular stuff. So but if you're interested, you can go back and read the papers that Google DeepMind has been publishing. This is a paper on AlphaFold 1. The paper on AlphaFold 2 is not out yet, but I mean, I'm pretty sure that it'll be a paper in Nature that will be coming out soon, talking about their difference in the first and the second competitors, right? So what we do is actually we do a little bit of public health, and our question was, if models can be trained to play Mario games, models can be trained to fold proteins, can they also be trained to take optimal decisions for public health? For example, vaccine distribution. We started asking this question way back in August of 2020, when it was evident that India may come up with a vaccine soon, right? So we thought, okay, we may come up with a vaccine, but vaccine is going to be a limited resource, right? It's going to be a scarce resource. How will we be able to allocate vaccine across the different states of India? Uh, if the vaccine was available in limited numbers, right? So that was the question that we started asking in August of 2020. And by September of 2020, we had an algorithm and a paper written up. Again, it is currently under review, but the dashboards and the preprints are all up out there, where we built a model called Deep Q network or Deep Q learning based network, right? And uh, we stacked it with another model which is called the contextual bandit model. So we used a DQN along with a contextual bandit problem. Why context? Because we actually wanted to uh, build in the context of states. As I said, India is a very diverse country. Each of the states in India is a very different setting, right? Some states actually have a high proportion of young people. Some states have a high number of frontline health workers. So these are all the contexts that go into the model, like ICU beds, hospital beds, ventilators, susceptible population in that state, recovery rate, death rate of that state, right? Age distribution of that state, and so on and so forth. And we saw that our models were actually learning. And way back in September of 2020, we were able to show that if we took an AI-based strategy such as this, and then calculate the number of cases prevented, we would actually prevent more than 100,000 cases on a monthly basis um, across India, uh, in comparison to a naive approach where we might just send more vaccines where cases are more, right? So this was way back in September. Now the situation is a little bit different. Now COVID has anyways fallen a bit, but now actually it's rising back again, and many states in India are actually showing a rise again. And again, we are worried about, are we seeing a second peak, right? But by going by the current numbers, we are saying that by our models, we'll be preventing about 15,000 cases on a monthly basis, if we were to take an approach which is more AI-based approach as compared to or models, as compared to approaches that for example current uh, policy is about distributing vaccines. And now we actually have extended this as a framework which is not just relevant to India but also to other countries such as the US, and very soon we'll be making it open source, and we hope to make it a plug and play sort of a platform where you can not just talk about vaccines but also talk about syringes, PPEs, anything that is resource limited, and basically look at some of those optimizations down the line, right? So that's a vaccine dashboard that we currently are running uh, uh, on our labs website as well. To finally end this talk, and to tie up all of these threads together, right? So AI in the next phase needs to be contextualized, right? So we have very different contexts across the world, and essentially we need to make models that are more precise. And how can we make models that are precise is by incorporating context. So contextual bandit is just one way of looking at this, but there's other ways as well, right? And one of the underappreciated forms of AI is actually models such as probabilistic graphical models, which 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 are based upon, and Bayesian networks, which are based upon the principle of conditional probabilities, right? And why I am saying this is because the real world has asymmetries. Many of the models that we talked about and many of the machine learning models actually just exploit correlations, right? But they do not exploit conditional probabilities. And correlations are asymmetric, right? But the real world has has asymmetries built into our decision making. For example, um, if I asked you in a given scene, what is the probability of seeing a wheel if a car was there in the scene? Your answer may be different from if I reverse the question and asked you, what is the probability of seeing a car if a wheel was seen? It may not be the same, right? The probabilities will not be the same because wheels come with many different types of vehicles, but mostly all cars come with a wheel. So those probabilities are different, right? So and this asymmetry of information needs to be actually exploited as a conditional probability, and that also can give you context by setting up a query that is conditional, right? In the healthcare setting, you can think of it as, for example, if you have to make a decision on if a patient is uh, having coronary artery disease, what is the probability of them being on low dose aspirin versus if a person is on aspirin, what is the probability of having coronary artery disease? Again, there are asymmetries that are built in, which means that you can actually learn these asymmetries directly from data, and that's when you can actually start building models that exploit these asymmetric relationships, and then the structures that are underlying in these asymmetric relationships. I don't have the time to go into these different kind of structures, but if you're interested, sorry, you can go back and read about probabilistic graphical models and Bayesian networks, especially of the variety that you can learn directly from data, and start building models with. Our experience with these models was very exciting. In way back in 2015, we built such graphical models which are explainable and contextual in a data set which was collected all across India on a single day. Okay, this was a data set on 200,000 patients collected all across India on a single day on patients who were visiting primary healthcare settings and reporting their uh, diseases, symptoms, and signs, right? And so what we were thinking about is that we know that diseases don't happen in isolation. So there's obviously there is going to be a network of symptoms and signs, right? So these networks will form clusters. These clusters will form communities in the network, and these communities can be tracked across age groups. And this is the similar diagram that I was showing you earlier, that you can track these communities across age groups. But then we extended it to a decision network where we built in more context into these models and showed that a lot of respiratory diseases, which is the major network module here, can be prevented just by providing clean cooking fuel in the districts of India, right? And that was possible because we were able to discover this model and this node, which is a parent node of obstructive airway disease and rhinitis, and we were able to query the model to show that it would actually obstructive airway disease would actually fall by half if we were able to provide more clean cooking fuel to the districts in India. Now you can imagine this we actually have a paper in IIII which did a similar analysis for the US, talking about how could we mitigate health inequalities in the US. And I would encourage you to go and read that paper. There's some pretty interesting insights there about what would mitigate health inequality in the United States using a Bayesian decision network setting. But also in the recent piece of work that we did, we also learned what would mitigate HIV transmission in sex workers in 5 different states of India. And we were able to show that one of the most important intervention in doing this would be financial literacy training. And we do these studies in partnership with organizations that work on ground, working with these community groups of, for example, sex workers or primary healthcare providers. And when we actually showed them our model, it's an explainable model because you can actually explore the model, you can query the model, you can ask questions. We have a platform for it, what we call Wiser. It's an R-based platform. They actually said that it is pretty intuitive because women who are more empowered financially are also more empowered to say no to unprotected sex. And we found that in our model in a very transparent way that financial literacy training had the maximum impact on preventing HIV transmission because these women were using condoms more often in their sexual encounters, right? So this is now being tested on ground as a pilot trial. But again, this would be a new paradigm, we believe, of using explainable AI models in public health settings on ground to really provoke studies that can be useful in public health settings. And then we can deploy these as dashboards. As I said, we have an application called Wiser that allows us to deploy these models as explainable AI models as web applications. So to summarize my talk, essentially AI in healthcare has a broad range of applications. You can think about structured data where data are neatly organized. You can think about um, uh, these help us bring up the underlying patterns. Unstructured data and modeling with unstructured data can actually generate new knowledge. For example, the way as I showed in Washkaro or in evidence flow. Reinforcement learning can help to make some decisions and to simulate scenarios. But to really make decisions in public health scenarios or in medicine, you need to take context into account. And that's where explainable AI comes into picture, because I don't think any clinician or any policymaker would deploy an AI model unless they are able to actually interact and contextualize the model and query the model in the language that they understand. And that's where contextual AI becomes really important. So with that, I'll stop, and I'd like to acknowledge all my team, my lab members and my colleagues who make all this work possible, students, and also our funding bodies which support our work, and our collaborators. Thank you so much. I will be happy to take questions.
Thank
Thank
you
you so
so
much,
much.
Dr. Sethi.
Yeah, we're that was a lot to take in, but we're really grateful to have you here with us. I realize we're a little bit running late, so if anyone has questions, I guess we can open the floor to those. And yeah, just being cognizant of, I know classes are starting soon for people.
Sure.
Yeah, I agree. The talk was very insightful. I learned a lot about everything you've talked about today. My question was a little bit on the application or the feasibility side. How do you think that AI can infiltrate into our daily life?